Look, it is indeed a pleasure to be able to talk. I know that I largely with Sarah self-organized the conference, but I think there are some things, we as ethics committees clearly should continue to think about. And in Australia, and it's such a broad question. And I was so happy to be able to invite Holly to talk because it just occurred to me about 3 days ago that she would actually be the best person probably in the world to talk about quality assessment of HREC. So she was very, very kind in agreeing to come on without much notice. I'm really looking forward to that. I hope this is going to, you might not agree with it, whatever. It's meant to be thought-provoking more than anything else, because I think continually when we look around the world at ethics committees, numbers, what is quality, what does it mean? And I'm not sure we ever really come up with the right answer. And I think this has been precipitated to some extent this year by, or maybe it was last year, by the development of the draft quality standards for accreditation of some HREC. So I thought I'd take a stab at introducing this, poking the bear. Hate me if you like. Don't really mind. I think it's about discussion. So, titled "Quality versus Quantity in Australian HRECs: Time for a Rethink." And like Lisa, let me of course again acknowledge the traditional owners of the land in which I am speaking from, the Turrbal and Yagara people in Brisbane. So I think if we the issue of quality and professionalization of ethics committees is not new. And, from talking with Nick Zepps during my time at the NHMRC, I'm fairly sure that Nick put together a paper in about 2005, if not earlier, about professionalizing ethics committees and rationalizing ethics committees. And yet, this has zero traction. It's had zero traction forever. Maybe one question is, does it actually need traction? But I sort of feel that we have an opportunity to be better. We have an opportunity to evolve. We have an opportunity to professionalize. We have an opportunity to ask ourselves what quality actually means and how we can evidence that. Even in Mark Taylor's talk in the last data session, Mark was talking about trustworthiness. Well, if we want to be trustworthy, we have to demonstrate that what our outcomes are, add value and add quality. And unfortunately, sometimes the absence of evidence does not mean there's an evidence of absence. Is a quality outcome one where participants are not harmed, because let's face it, 99.99% of the time that is the case? Or is it the way in which we go about things? So I thought I'd start just by looking at the McKeon review in 2013, where they said, talking about ethics committees that reviewed clinical trials, they were suggesting 8 to 10 professionalized ethics committees. And it says they're using a similar model to these companies if needed. Now, I won't go into the companies. I think we all know who or what we're talking about, at least in this country. And of course, in the US, you have entities such as the Western Institutional Review Board that reviews a lot of applications for clinical trials. But 8 to 10 ethics committees was very aspirational. Clearly, it got no traction. That was just way beyond the pale. I mean, come on, who in their right mind wants to get rid of their ethics committee and say, no, someone else can do this for us? Is that, because people may see it not as a sign of sophistication, but as going backwards, which I think is not right. I think a sign of sophistication is, well, we have a limited amount of resources. We can use these in a better way. We know that another ethics committee has the capability and quality to do this. Why shouldn't you let people do this? And so 8 to 10 committees nicely works out around one per Advanced Health Research Translation Centre in Australia. What that means is you could theoretically have, I don't know, Health Translation Queensland having a single administrative support for as many ethics committees in Queensland as you wanted to either review health or, university-related information. It doesn't matter. The point is, rationalization can happen. Now, I guess the question is, what does professionalization look like? Because the McKeon report wasn't very clear about professionalization. So professionalization might be, for example, paying all or external members. And, my personal view, and one I recommend regularly, is that chair people should be paid and external members should be paid. We cannot anymore live in a paradigm where we take this for granted, because then you can have accountability, you value people for the time, If they feel valued, they're more likely to put effort into their job. Does professionalization look like consolidation by aligning with advanced health research centres? Actually, I think it probably does. I think it would be great to see a smaller number by aligning with an advanced health research centre. Professionalization may look like accountability for training. And of course, this conference is a wonderful example of resources that can be used for training. Accountability for attendance, and accountability for the type of deliberation and decision-making that occurs. Now, that's contentious because no one has ever managed to get a handle on the quality of deliberation. And even recently released draft guidance does not do that. So I think this is where I'm thinking of myself. But also, it might mean meeting markers of quality, timeliness, and transparency. Well, timeliness and transparency, so you can get your ethics review done within the 60 days, tick that compliance box. That doesn't mean quality, that just means you get it done within a certain length of time. Transparency is important. People should always know what system is going to be used. What are markers of quality? Why do we need quality in ethics review? Especially because I've said, if the ethics application goes through and no participants are harmed, isn't that a quality application? And the answer, and what I'm fairly sure my two colleagues will back this up, the answer to that is absolutely not. So if we look at quality standards over the last 12 years, in 2011, we had the National Certification Scheme for the Ethics Review of Multi-Center Research, which only assessed the ethics review processes of the institute that was responsible for the ethics committee. I know because I was part of the development of that. It was done by Ellen Kitson in large part, and the NHMRC. And of course, I was involved in certifying ethics committees. It was reviewed in 2016, but that's 8 years ago. And so nothing has moved much since then. Did it assess quality? Absolutely not. What did it assess? It assessed box ticking exercises. How quickly can you get your minutes out? It did make reference to the use of a national statement, which Colin Thompson mentioned this morning. And you'll see there in April 2012, Colin and his company developing best practice in human ethics review. So an effort to provide guidance to ethics committees about how to achieve quality outcomes, yet without dealing in the quality of deliberation. And now this year in last year, July 23, and I know Conor Brophy will talk about this either tomorrow or Friday, draft quality standards for institutions and human research ethics committees under the National Mutual Acceptance Scheme. So there are quality standards. Do they assess quality? Let me not comment on that, but just to say, I think we can actually do better. So what are the markers of quality by an HREC? That no participants are harmed, that all regulatory requirements were met, there was good and robust discussion, deliberation, or the outcome occurred within timeliness. I would argue these are more compliance in large part than they are markers of quality. You tick a box, you can say, yeah, we get it out within the 60 days, no participants were harmed, we've met all our TGA requirements or CTN requirements, and yes, of course, we have good deliberation. And so I guess the question is, can quality even be measured? Like, is it actually tangible? And the answer is, at least in our paradigm, the answer to that, I think, is no. So I think here are some better surrogate markers of quality review by an ethics committee. Do you have the right resources? Emma Maloney talked about using AI for pre-review, pre-screening, but that the human input is incredibly important. Are there sufficient members to engender the sharing of a wide variety of opinions? Colin Thompson talked about that diversity of views. Having 8 members, which is mandated in Australia, is probably not enough to have that diversity of views. We will see that in the US, it's only 5 members. Clearly, that's not enough to have the right number of views, especially when you're taking lived experience into account. So how do we deal with that? Having a single source of truth. We have a national statement. New Zealand have the Health Research Council guidelines. The US has their human research protection, and I'm sure Holly will tell me about when she gets to it. Point is, we have a reference point that we should all be using. We should all be referring to that. At least then we have a grounding and consistency in what we do. No one can come back to us and say, you're making up questions out of out of the clouds, when we say, well, if you go to section 2.3.10 of a national statement, here are the conditions for a waiver of consent, and you haven't met them. Are all members referring to this source of truth? Answer, definitely not yet. are we using a single ethics application form? We know that 60 to 70% of ethics committees use the Human Research Ethics application. In my view, we should all be using the same form. No question about it. Are there sufficient tools for training of members? And do we only focus on essential issues versus nice to haves? These to me are better surrogate markers of quality. Do we do all of them? Some of us certainly try to do them. We probably don't manage them all. But I think to me, this is quality. And ethics committees really should be looking at these markers as quality, as well as aspects such as numbers. Now, what I just thought I'd do is give you a quick snapshot of ethics committees around the world. And I hope you can all see this. I thought I'd just, for the literature I could find, US, UK, Australia, Switzerland, New Zealand, and I have put WA in there. And for our WA listeners, I know WA is not a country, even though you would like it to be, some of you sometimes, but I thought it's useful because they've at least gone through a process of rationalization of committees. So here we go. In the US, 2,300 committees, according to 1,800 institutions. That includes a lot of university, as Holly has pointed out to me. About 2 entities, including the Western IRB, is responsible for 40% of clinical trial or health-related applications. That's amazing. The question then makes me wonder, what do these other ethics committees do? In the UK, 67 committees, which are governed by the Health Research Authority, with an average number, a mandatory number of 15 to 18 members on it, and an average number currently of 12. In Australia, we have 192 committees. Now, it's gone down in the last couple of years, but 192 committees, of which 54 are certified. So even just compare 67 to 54, we have a shed load more committees than we probably need. Our mandatory number is 8. That doesn't seem many, but when you compare that to the US, whose mandatory number is 5, it's obviously better. The average number of members, I couldn't find out from the Institutional Annual Compliance Report from the NHMRC. But of them, 8 committees don't meet quorum, 72% accept the Human Research Ethics application, and about 40% review less than 30 applications per year, maybe even less than 20. So it's less than 2 applications per meeting. Please tell me how you can evolve unless you're meeting some of those other quality markers if your expertise is not significant enough to broaden your horizons. I think that's a fair argument. Switzerland, really fascinating, 7 committees, cantonal, 28 members per committee. New Zealand has rationalized their committees. They have 17 plus 3 statutory, of which 11 are university ones. They have 4 health and disability committees. They have a mandatory number of 7 and an average number of 10. So why I wanted to point out WA is because they've gone through a bit of rationalization. It was recommended that they went to 3 health-related public health ethics committees. They bit the bullet and went to have a single administrative support framework for all of their public health committees. And now they have 3 under that. So clearly you can have as many committees as you want, but they've taken that approach of having a single administrative framework, which is good from the perspective of rationalization. How it's working, I couldn't actually comment. But what this slide kind of says to me is there's a variation in the number of members per committee, amongst other things. And that really, do we need more members per committee to actually be able to provide that diversity of views, especially when it comes to complex applications? And I know when I was chairing the Royal Brisbane Committee, I had about 40 members, 40, not all turned up at once. On Uni of Queensland, I had 15. I like that number, but I don't think that 8 is actually enough. So what do we have for members, for tools and training for members? Well, of course, we have fee-for-service training courses. We have training aids like these videos or HREC, from the HREC conference. You can use national statement quizzes, for example. You can use mentoring. You can have an internal reflection on performance, so we do that every 3 or 4 months. You could indeed have an external assessment of performance. And I do feel this is where a National Association of Ethics Committee chairpersons would be a really useful adjunct to draw on that expertise to at least be able to say, hey, are we doing the right thing? And the last thing, or one other thing you can do, is you could have these so-called mystery shopper applications. And I'm not going to say too much because Lisa's going to talk about them. But, we have surrogate markers of quality that we can, and we have the tools and training to be able to implement them. The fact of the matter is, right now, we don't. Can we say we're meeting quality standards? I don't think we can say that. Can we say that any new standards for quality are going to help us get there? I'll wait to answer that one a bit further, but I think it's important from the perspective of this talk and this session to say we need to continually look at quality assessment and make sure that we as ethics committees and the institutions that support us are helping us get where we need to be so that we can help establish trust in ethics committees, not just tick boxes for compliance, not just keep our ethics committee because we feel we need it, when indeed another ethics committee could quite easily do the work for us, and we'd be saving ourselves significant amounts of money in resources. So that's a bit of a soapbox, just my personal view, of course. But now what I'm going to do is I'm going to hand over to Holly. Not Holly, well, I'm going to let Lisa introduce Holly. But thanks for listening. I think it's important to consider this. It's a little bit provocative. We have to continually look at quality, but I know that Holly is much better qualified than I to talk about quality assessment on IRBs and ethics committees. So Holly or Lisa, over to yourselves.
Thank you so much.